We're going to go ahead and talk about the remainder of our pharmacology section of Unit M. So this is chapter 40. This is our cardiac glycosides in your pharmacology book, cardiac glycosides, anti-anginals, and antidysrhythmics. So this is your heart failure. So we're going to talk about heart failure first. So acute heart failure is where the heart muscle weakens and enlarges. So the heart loses the ability to pump blood adequately and the compensatory mechanisms fail. So over time, if we're not pumping blood adequately, our heart will beat faster and harder to pump blood out, which can essentially cause atrophy of the heart or an enlarged heart muscle. The lungs and periphery become congested at that point because we're not actually pumping blood out to the tissue as effectively as we should. So from the pathophysiology standpoint of this, we talked about this pretty in depth in class. So we talked about the preload and the afterload and the stroke volume. I will try to find a video to put in your supplemental information about this process. And then we talked about the difference between the right-sided and left-sided heart failure. So if it's right-sided, it's going to back up into the periphery. If it's left-sided, it backs into the lungs. So these are your categories of heart failure. So this is what the American Heart Association describes as heart failure stages, so stages A through D. This table shows stage A is at high risk for heart failure, but without actual structural heart disease. B is structural heart disease, but with no signs or symptoms of failure. C is structural disease with prior or current symptoms of failure, and D is refractory failure requiring specialized intervention. So what are some things we could do for non-pharmacologic treatment of heart failure? So these are the things we talked about in class. So if you have someone with heart failure, some of the interventions you might do are to limit their salt intake, limit their fluid intake, change their diet, right? We also want to educate them about limiting alcohol, smoking, lifestyle choices as a whole, exercise, weight loss. Some of the diagnostic tests that we use for heart failure include the ANP, which is the atrial natriuretic peptide, and your BNP, which is your brain natriuretic peptide. The BNP is the more common one, and so desired value is less than 100, and essentially this just helps aid in the diagnosis of heart failure. Because brain natriuretic peptide is secreted from cardiac cells, and so when this is elevated, it helps us differentiate whether or not like shortness of breath is due to heart failure versus like a lung problem. So let's take a quick look at this video.
This upcoming school year, I will be a senior in college majoring in psychology, but I have been using grammar.
Hello. In this video, we will talk about 4 types of effects of external stimuli on heart: chronotropic, inotropic, dromotropic, and bathymotropic. Welcome back to nonstopneuron.com, where learning medical concepts is as easy as watching cartoons. Let's get started. Cardiac tropism describes the effect of external stimuli on the heart. See, the factors acting on the heart affect different parameters of heart functions. So they produce different types of changes in heart activity. These changes are broadly categorized into 4 types: chronotropic effects, inotropic effects, dromotropic effects, and bathymotropic effects. Here, the meaning of the suffix tropic, which is common for all the words, is change. Now let's see each of them one by one. First, chronotropic effects. Chrono means time. And of course, the most important cardiac parameter related to time is heart rate. That is, how many times the heart beats every minute. So the chronotropic means changes in heart rate. Positive chronotropic means an increase in heart rate, and a negative chronotropic means a decrease in heart rate. Now, we know that heart rate is controlled by the SA node, the pacemaker of the heart. So the factors affecting heart rate acts through the SA node. For example, adrenaline speeds up the SA node and thereby increases the heart rate. So it is called a positive inotropic agent. On the other hand, acetylcholine slows down the SA node. So it decreases heart rate. Or in other words, it produces negative chronotropic action. So these were chronotropic actions. Next we have inotropic effects. Ino means force and tropic means change. So the inotropic effect means a change in the force of contraction. Positive inotropic means an increase in the force of contraction, and negative inotropic means decrease in the force of contraction. Now, the main factor determining the contractility is calcium concentration in cardiac muscle. So the factors affecting contractility acts by changing calcium levels in the cardiac muscles. For example, cardiac glycosides like digitalis cause calcium loading in heart muscles. This increases force of contraction, also called positive inotropic action. On the other hand, calcium channel blockers decrease the calcium levels. This leads to a decrease in force of contraction, also called a negative inotropic action. So these were inotropic actions. Next are dromotropic actions. Dromo means running. Okay, but who's running here? Impulse. We know that impulse is generated at SA node, passes through AV node to reach the ventricles. Dromotropic means change in the speed of this impulse conduction through the AV node. Positive dromotropic means increase in the velocity of conduction, and negative dromotropic means decrease in the velocity of the conduction. Obviously, dromotropic effects are produced by acting on the AV node. For example, adrenaline increases the velocity of conduction through the AV node. Thus, it produces positive dromotropic action. And cardiac glycosides decrease the velocity of conduction. Or in other words, they have negative dromotropic action. So these were the dromotropic actions. Now the final one, bathymotropic actions.
Okay, we're gonna stop there because we don't really need to know as much about bathymotropic as we do the other three. So, that should give us a pretty good overview of glycosides and how they work. So, when we talk about cardiac glycosides, the most common one you're going to see is digoxin or digitalis. So you may hear that referred to as either or, but digoxin is how it's most commonly referred to. So digoxin is a positive inotrope. It increases contractility, it increases stroke volume, it decreases preload, and increases blood flow. So it has a negative chronotropic effect. So this is a very complex drug. So it's increasing the contractility, but it's actually decreasing the rate. It is a negative chronotrope and a negative dromotrope. So it's also decreasing the conduction of that impulse, so that electrical impulse. So there's a lot of side effects associated with digoxin, including bradycardia, dysrhythmias, nausea, vomiting, headache, confusion, so a slew of adverse side effects. So one of the primary reasons it could obviously cause bradycardia is because of all these things we just talked about. So it acts on all of these things. So if you're giving too much, or if the dose is incorrect, then it could definitely cause a bradycardia or some kind of dysrhythmia or adverse reaction. So it's easy to overdose or patients who are not metabolizing appropriately for them to accumulate this drug in their system. And so this is something that is usually monitored by lab work. And so there is an antidote known as the digoxin immune fab, which binds with digoxin and excretes it in the urine. However, when we talk about giving digoxin, we want to make sure that we are monitoring lab levels to measure digoxin levels in our patients, and you will see that a lot on people who are on long-term digoxin. So for the antidote, these are some things that have interactions with that antidote, including diuretics, cortisone, and antacids. So when we talk about the clinical concepts or the clinical judgment of digoxin, this one is actually really important when we're talking about doing like a baseline assessment. So before you ever give digoxin, you want to obtain a baseline pulse rate. You want to have them hooked up to their EKG monitor, or you want to listen to that apical pulse rate to obtain their heart rate. Because if their heart rate's already very, very low, it may be something that's clinically contraindicated. We may not want to give that. And you may want to let your provider know about that before if it's ordered and that's something that you're having to give. You may want to contact your provider and double check. All of these things are things we need to assess for, including ischemia, tissue perfusion, and then teaching. We want to make sure our patient understands how to check their own heart rate if they're taking oral digoxin daily, and that's something that they need to assess. And so these are the things that we would want to assess on our end. So apical pulses, signs of peripheral edema, what is their serum digoxin level already. So like if you get a lab back that says their serum digoxin level is elevated, you may need to hold that dose for that day until you clarify with a provider whether you want to give that or not. Serum potassium levels, and otherwise, we want to instruct the patient to always report if they're having any adverse side effects. So that is digoxin. So we'll move on to phosphodiesterase inhibitors. So milrinone is the primary phosphodiesterase inhibitor that we talk about. So they're a positive inotrope, so increasing contractility, and they inhibit the enzyme phosphodiesterase. So they increase your stroke volume, your cardiac output, and promote vasodilation. So these are, we usually do not give these via IV longer than 48 to 72 hours at a time. It's a pretty high alert medication. We don't want to cause any long-term dysrhythmias. So these are things that are usually given very short-term for heart failure patients. Other things used to treat heart failure include vasodilators, angiotensin converting enzyme or ACE inhibitors, angiotensin 2 receptor agonists or ARBs, or ARBs, diuretics, beta blockers, and hydralazine. So we're going to go into detail on all of these other areas. So angina is what we call, there are two different types of angina, and there's classic or stable, and then there's unstable. So usually classic or stable is not as dangerous and is usually predictable, like if you've been up walking or the patient's been up mobilized and they're having chest pain, but that chest pain goes away whenever they rest. That's what we call stable angina. Unstable is whenever it occurs with any kind of non-precipitating factor. So like it just happens out of the blue, like they're sitting in their chair and all of a sudden they're having crushing chest pain, or any kind of just nagging, or it's increasing in strength. That's what we call unstable angina. And so that occurs frequently with any kind of progressive, like it's a precursor to the patient having a myocardial infarction. And so there's also variant types of angina, and those are known as the Prinzmetal or vasospastic angina, and those also occur during rest, and those are not as like common, but you do need to know the difference between classic or stable angina and unstable. So our nitrates are our first-line drug for angina. So these are what we call anti-anginal drugs. So the action of a nitrate is to promote vasodilation. So this would be like nitroglycerin. You will see patients come in with chest pain, and if it's indicated for that chest pain, they will receive nitro. You can give nitroglycerin in many different routes, so sublingual, translingual, topical. You'll see it as a paste. A lot of times they will paste it directly onto their skin, or it comes in small, tiny pills that you put under your tongue. Those are the most common ways to give it. So this is a very, very potent vasodilator, and it can cause it can cause chest pain to decrease, and but if you think about the action of vasodilation, so if you're giving this drug and the next thing, or the next thing you should be assessing for is hypotension, because if you're dilating the blood vessels that significantly, most of the time it's going to tank their blood pressure pretty quickly, and they almost always complain of having a headache and feeling really lightheaded, and they feel hot because their face is flushing, and that's because of the vasodilation. So those are some things we need to assess in our patient and just reassure them that those are usually normal findings whenever they've had nitroglycerin. So that is your primary nitrate for angina, the treatment of angina. So another anti-anginal drug is a beta blocker. All of your beta blockers are going to end in LOL, okay? The OLOLs. So beta blockers this is where we get into that beta alpha receptor business. So beta blockers block beta 1 and beta 2 receptor sites. So these work when we talk about beta 1 and beta 2, that's your heart and your lungs, okay? So beta 1 is the heart, beta 2 is the lungs. They block the action of the catecholamines, which is epinephrine and norepinephrine. So by doing so, it decreases the workload of the heart and the oxygen demand of the heart, because if you're blocking the beta receptor in the heart, then we can't stimulate it. By stimulating the beta receptor, you would make it beat faster. It's responsible for cardiac contractility. So if you administer a drug that blocks that receptor, a beta blocker, then we are primarily decreasing cardiac contractility. So the direct action of these drugs will lower your heart rate. So oppositely, side effects of these can obviously cause bradycardia, hypotension, and dizziness. So if we've decreased it, if we've given too much, or the dose is incorrect, then obviously we could potentially see some of these things. And you will see this every now and again on somebody who's taken too much beta blocker, or they took a dose in the morning and forgot they took their first dose, and then they accidentally took a second dose. So they may come in and say, I just feel really dizzy, and that's because they've tanked their blood pressure out because they've taken way too much of their medication. And so if it's blocking that receptor and decreasing the heart rate, that means we're not pushing out we're pushing out blood, but it's not pushing out as quickly. So if you take too much, then you have the potential to not perfuse as quickly, so you're going to feel lightheaded and you're going to feel dizzy. So let's talk about none of these drugs. So you'll see on the bottom a caution, like do not abruptly discontinue. Like we don't ever want to, especially with cardiac medications, we never want to abruptly discontinue cardiac medications. Our next class is calcium channel blockers. So this is for the treatment of angina as well. So these do not always have the same ending. So these could be these are varied. So verapamil, nicardipine, diltiazem. So these are all things that these block the calcium channels in the heart. So when we watch that video, stimulating that calcium channel is primarily responsible for the inotropic effects in the heart. So if we administer a calcium channel blocker, it is going to have a negative effect on the contractility or the inotropic part of the heart. So these relax coronary artery spasms and peripheral arterioles, and they decrease contractility after load and resistance. They reduce the cardiac workload and oxygen demand. So again, some of the side effects from these can be dizziness, flushing, headaches, hypotension. Just some of these things are dose dependent. So again, if you've given too much, or if the patient's not used to the drug and like their heart is used to working hard and their body's used to the state it's been in, and you suddenly administer a drug, it can often cause some of these side effects in a patient. So let's talk about all of our anti-anginal drugs, when we talk about the clinical judgment, these are the things we need to think about whenever we're doing our assessments, right? We always need to have a baseline assessment for any kind of cardiac drug. We want to make sure we're assessing for tissue perfusion and for all of those things that are potential side effects, like our dizziness, our hypotension. And then again, on our assessments and on our goals, the goal of giving a medication like this or an intervention like this is to resolve that angina and ensure that it has decreased or subsided. So we will move on to our next set of cardiac drugs, which are our antidysrhythmics. You'll see a lot of these kind of drugs in your what am I trying to say? Your ACLS protocol, so like your advanced cardiac life support protocol, so where you're running a code and you're giving like all of your epinephrine. Lidocaine is actually an antidysrhythmic inside the ACLS protocol now that can be given, and it is a sodium channel blocker, so it can actually directly work on the heart. So these antidysrhythmics that we're first going to talk about are your sodium channel blockers. So if we talk about a dysrhythmia, that means that it's anything out of that normal sinus rhythm, right? So it could be bradycardia, could be tachycardia, could be AFib, could be all of those things. So when we talk about sodium channel blockers, there are three different kinds. So A, B, and C. So the first type, slow conduction and prolonged repolarization. The second type, slow conduction and shortened repolarization. And the third type, prolonged conduction. So when we talk about repolarizing, that's talking about the electrical impulse of that heart. So that's basically like like when we talk about repolarizing, that's that recharge that lets the heart rest for just a second and allows the recharge of that electrical node to fire again. So that's what I'm saying. Whenever it prolongs repolarization, it prolongs the charge of that electrical impulse. So class 1 of our antidysrhythmics are sodium channel blockers, and class 2 of our antidysrhythmics are beta adrenergic blockers. So beta adrenergic blockers decrease our conduction velocity and automaticity and recovery time. So, and then there are several others, are class 3s and class 4s. So these are your adenosine and amiodarones. They prolong repolarization, and then they also prolong the action potential duration. So a lot of this is very, very in-depth. Some of these cardiac drugs get really, really in-depth. So when we talk about our cardiac action potentials, that's what we're talking. Again, we're talking about that electrical activity of the heart. I don't really expect you to know that as much as I expect you to know like the actual drug and that it is a cardiac drug and it is responsible for how it works on the heart, essentially. I don't really expect you to know as much as far as like the electrical like activity. So again, for our antidysrhythmics, adenosine and amiodarone. Amiodarone is, let's see, get back over here to the right page in the book. So amiodarone is a drug that is going to prolong repolarization. These can be used in the emergency treatment of ventricular dysrhythmias. And then our calcium channel blockers. This is the fourth class of calcium channel blocker, and so like verapamil is this calcium channel blocker that blocks the influx of calcium and decreases the excitability, so it is a negative inotrope and decreases contractility. So the nurse identifies which drug as a calcium channel blocker used for the treatment of dysrhythmias. When we talk about calcium channel blockers, so we can automatically take two of these out, right? So esmolol and sotalol, those end in OL, so those are LOL, so those are our beta blockers, so we know it's not those. We just talked about flecainide being an antidysrhythmic, and so diltiazem is our option for a calcium channel blocker. Okay, so let's move on to diuretics. I'm powering through this. Okay. So the purpose of a diuretic is the majority of the reason we give diuretics is to reduce hypertension and decrease edema. Those are the two main purposes of diuretics. So when we talk about the types of diuretics, everything listed here is a different type. So thiazide and thiazide-like, loop diuretics, osmotic diuretics, carbonic anhydrase inhibitors, and potassium sparing. And these work on different parts of the kidneys to diurese your patient. So when we talk about our kidneys, this is a little graphic of our kidneys. So when we talk about where that diuretic is working at, we're talking about the different areas that it could potentially be working. So if we say it's working on the loop of Henle, then we are referring to this portion of the kidney right here. If we talk about that working on, and so like this little infographic actually tells you what's working where. So your loop diuretics work here. Your potassium sparing diuretics are working in this collecting tubule, which is here. Your thiazides are typically working over here in this distal tubule. And then your osmotics work over here in the proximal tubule. So it's a really nice little infographic to tell you what diuretic is working where in the kidney. So your thiazide and thiazide-like diuretics, like your hydrochlorothiazide. So that's this HCTZ is an abbreviation for hydrochlorothiazide. So hydrochlorothiazide acts on the distal convoluted renal tubule that promotes sodium, chloride, and water excretion. And the use of this is for hypertension and peripheral edema. Some of the side effects include dizziness, headache, hypotension. If we think about why, it could be potentially because we've over-diuresed our patient, and so our fluid volume has gone down. It could potentially also affect GI distress, cause constipation because we are pulling water out, right? And then also some electrolyte imbalances because we're shifting our fluids, hyperlipidemia, and hyperuricemia. It is contraindicated actually in renal failure. So if we think about renal failure, that means our kidneys are not working effectively. So if we give a drug like a diuretic that its primary mechanism of action is to work on the kidneys. If the kidneys don't work, then the drug is not going to be effective. So other interactions which we need to always consider are a lot of our cardiac drugs, so like digoxin and lithium and our other antihypertensives. So we want to make sure that we are not giving something in conjunction with a diuretic that could potentially be dangerous. So when we talk about the clinical judgment, what we need to be assessing when we give diuretics are our elimination. So if we've given the diuretic, we want to make sure they're eliminating appropriately. So we might want to look at our intake and output. And then we also want to assess vital signs, weight, all of our lab work. We want to check for edema, see if our edema, we should see a decrease in edema. We should theoretically hear clearer lung sounds, especially if they're in fluid overload or if they have fluid on their lungs. And so those are some things we should be assessing for when we talk about the clinical judgment of diuretics. And another thing we always want to be assessing for when we give diuretics is our blood pressure, because if we are causing a shift if we're diuresing, so we're getting rid of fluid, that can automatically drop our blood pressure because we're decreasing intravascular fluid. So we always want to be mindful of that, and it can often make patients really dizzy. So these are just kind of reiterating those things. This one can actually cause a few sleep disturbances. So one of the suggestions on this is that the patient take the drug early in the morning. And then obviously we want to instruct our patient to change positions slowly because it can cause dizziness because we are pulling fluid out, right? So we're changing what's inside that vasculature. So our next diuretic that we're going to talk about is our loop diuretic, which is furosemide. So furosemide acts on the ascending loop of Henle. These excrete water, sodium, potassium, calcium, and magnesium. So when we talk about this one, we talk about what it excretes. It's not selective in what it excretes. So this one is actually very important when we talk about potassium. So this is not what you would consider a potassium sparing diuretic. It will help it will let your body shed potassium. So something we want to assess in these people is always their potassium level, because it can cause them to have low potassium. Potassium is a very important electrolyte for cardiac function, and so if our potassium level is too far off and out of range, it can cause cardiac dysrhythmias. So when we talk about Lasix, potassium is something we must really consider, and we must always monitor that potassium level. And it states down here, so some of our common adverse side effects are electrolyte imbalances, hyperglycemia, dizziness, headache, weakness, orthostatic hypotension, hypercholesterolemia. All of these kind of come with a slew of side effects. So, let's see. Let's talk about, and again, so when we talk about the clinical judgment of this, we talked about assessing our vitals, assessing our lab work, watching for fluid overload. Conversely, these can sometimes cause hypernatremia because you are not, how do I explain that? Your body does not, salt is often hanging on to the fluid that is still in the tissue. So a lot of times you will you'll have given like Lasix, and it won't actually flush the sodium out, and so it can actually hang on to salt. So you may see some hypernatremia. Hypokalemia, so that means low potassium, so that is an incredibly important area to note. Monitor potassium levels, especially when a patient is taking digoxin. Okay, let's talk about our osmotic diuretics. So the primary osmotic diuretic you're going to see is mannitol. Mannitol increases sodium reabsorption in the proximal tubule and the loop of Henle. So it also helps excrete sodium, chloride, potassium, and water. This is primarily used in like your neuro areas and your neuro ICUs, especially if they've got a increased intracranial pressure from a head injury or a stroke. A lot of times they will use mannitol to decrease their ICP or IOP, which would be intracranial pressure and intraocular pressure. And it also promotes excretion of toxic substance. Mannitol is actually pretty. I have actually administered it a few times, but it is very, very potent. But you have to monitor neurological checks in these patients very, very frequently. So some of the reactions to this can include blurred vision, electrolyte imbalances, GI distress, edema, pulmonary edema, heart disease, heart failure. This one's actually contraindicated in heart disease and heart failure. Your book does not actually expound upon why, which is very strange. And then another thing to note about mannitol is that it can actually crystallize whenever it's sitting at a low temperature in the vial, and so in order to dissolve the crystals, you should warm the solution. So carbonic anhydrase inhibitors. So this is like our acetazolamide. So our action of these is to block the action of the enzyme carbonic anhydrase. And it promotes excretion of sodium, potassium, and bicarb, and it is primarily used to decrease intraocular pressure in patients with glaucoma. So side effects again can include confusion, hypotension, GI distress, fluid and electrolyte imbalances. You should always note that a side effect of your diuretics could potentially be fluid and electrolyte imbalances. Crystalluria, renal calculi, and hemolytic anemia are all other adverse reactions to this. And then our potassium-sparing diuretics do exactly what they say. So these actually spare potassium from being excreted, so you retain potassium. So they block the action of aldosterone. So these work by blocking the action of aldosterone, and we're going to talk about the ROS system in our next lecture. So this may make a little more sense. So this part of the lecture will actually coincide with your fluid and electrolyte lecture because of the diuretic portion. So we want to talk about promoting sodium and water excretion, and we usually use this in edema due to heart failure and cirrhosis of the liver. Some side effects of this include, again, same things: dizziness, headache, weakness, GI distress, hyperkalemia, muscle cramping. And so we always actually, when we talk about this one, we want to make sure that we are watching for hyperkalemia in this kind of a diuretic because it is potassium sparing, so that means that it may not be excreting out of the system appropriately. So we want to make sure that we're monitoring potassium levels in these patients. We want to recognize cues such as blood pressure or vital signs, all of our baseline vital signs, and then in general, all of our goals for that patient. We should assess for those. And then again, always monitor your urine output in any kind of diuretic and vital signs. And this one talks again about administering spironolactone to avoid nocturia, which would be like if you give it at night, they're going to be up peeing all night, right? So we want to promote giving it in the morning, and then also advise these patients to monitor their food intake that has high potassium in it because we don't want to further exacerbate that potassium level. So your practice question for this is: a patient is taking furosemide 40 milligrams daily for heart failure and hypertension. What is the most important for the nurse to assess in the patient for the development of low potassium, sodium, magnesium, and elevated calcium, low potassium, sodium, elevated mag, and calcium, low serum potassium, sodium, mag, and calcium, and low potassium and sodium with magnesium and calcium remaining normal. So this one does not spare anything. So this one is, your answer is low serum potassium, sodium, magnesium, and calcium. So furosemide or Lasix does not spare anything. So it's going to excrete all of those. Okay. And then question 2, which statement will the nurse include when teaching a patient about loop diuretics? Take medicine at bedtime. So we know we don't want to do that because they're going to be up peeing all night. Take medicine on an empty stomach. Rise slowly from lying or sitting or to standing to prevent dizziness, and avoid fruits and vegetables. So most likely we don't want them to avoid fruits and vegetables. We just probably want to make sure that they're monitoring their intake. But the most appropriate answer here is to rise slowly from lying or sitting because it can cause that orthostatic hypotension. Okay, so let's take a break and then we will talk about antihypertensives here in just a second.